Yeah, my name is Philip Freeman. I'm trained in the UK and moved to Denmark for post CCT or post qualification interventional cardiology sort of fellowship, and ended up staying. So that was 5 years ago. I'm an interventional cardiologist. I also do cardiac MRI, and in terms of interventional cardiology, I do PCI and TAVI. There's my Twitter handle there in case any of you are tweeters. So just wanted to cast your mind back to, seems like a long time ago now, 2010. I was still a cardiology trainee, actually, back then. And we've got the partner trials, two partner trials. I'm going to focus mostly on medical versus TAVI. And I think the context of this is very important. This was a period where between 30 and 40% of patients with severe symptomatic aortic stenosis were turned down for surgery in the pre-TAVI era. And that was on the basis of age, comorbidities, et cetera, et cetera. So we had a large population of untreated patients with critical aortic stenosis, and these patients were bouncing in and out of hospital in their last year or two of life on a frequent basis. In the medical therapy arm of partner, as you can see, over those 2 years, extremely high mortality or repeat hospitalization, cardiovascular mortality and all-cause mortality, absolutely dismal. So a large population of patients that were really quite desperate. Death in TAVI compared to standard therapy up front in the 30 days was had a trend to be higher, but in the 1 year after TAVI implantation, an absolutely phenomenal 19% absolute risk reduction in all-cause death. There's very few therapies that can give that kind of absolute risk reduction. Very few, if any. The flip side to that was a major stroke in the TAVI arm, significantly higher. This was both at 30 days and a trend at 1 year, and at all stroke and TIA, again, significantly higher in the TAVI arm. And of course, if you're an 80-year-old having a significant stroke, is a big deal. And that's something that certainly we all need to speak to our TAVI patients about who are older, because it may be they're more scared of a stroke than they are of severe aortic stenosis and suddenly dying that way. Major vascular complications in partner were also a little eye-watering in both 30 days and 1 year. Major vascular complications around 16 to 17%. Major bleeding, again, all the way up to 22% at 1 year. So really quite significantly high. And of course, the early technology has improved since then. We'll cover that later. So in summary, partner one, a very quick summary, massive absolute risk reduction when compared to medical therapy. And I didn't talk about the surgical arm, but an equivalent outcome when compared to surgical valve intervention in high-risk patients. There were, however, significant vascular complications and a significant major stroke complication when compared to medical therapy. Technology has improved since then considerably. It's 10 years. The most significant improvement really has been sheath and valve crimping and delivery devices, which have enabled us to come down from a 22 to 24 French sheath in the first iterations of balloon expandable valves, all the way down to 14 or 16 French with various technologies. That obviously has been led by the technology of the valve, the delivery system, but also in the actual sheath itself, having now using expandable sheaths, which are much more gentle on the vascular on the iliacs. With an associated massive reduction in major vascular complications and bleeding. Other changes and improvements have been the development of the valve itself. Here you can see the iterations of the Sapien valve. A is the original, B is XT, and C is Sapien 3. The final iteration is called Ultra and is fairly similar to Sapien 3, both with external skirts which significantly reduce paravalvular leakage. And then the advent of much larger valve sizes, 30.5 and 32 millimeter valves. Those two are Merrill My valve, which we use in our institution. So flipping very quickly, I know most of you probably know this, but flipping to partner 2, which serves as a good way of highlighting how the technology and technique and the treatment has evolved. Partner 2 was intermediate risk. That means a STS score of between 4 and 8%. Surgical standard therapy versus TAVI. This was with a primary endpoint that was a disabling stroke plus mortality. It's a non-inferiority study. The outcomes of that were equivalent over 24 months, equivalent amounts of stroke and reduced all-cause mortality. You can see a very early splitting of the Kaplan-Meier curves there. It's just catching up. Primary endpoint events, you can see it 30 days and 2 years. Basically, everything is equivalent with no significant differences between all-cause death and stroke and the individual outcomes of all-cause death, cardiovascular death, all-cause stroke and disabling stroke and TIA. And you can see there, actually, the stroke rates in these patients, obviously they're lower risk of stroke than they were in partner 1. But they're coming down to 5.5% in TAVI at 30 days and 6.1% in the surgical arm, so very equivalent. That's partner 1 and partner 2, just to give you an idea of where TAVI came from, where we're at now. We've moved obviously to partner 3 in a low-risk population, those with a STS score below 4%. But this talk is entitled Tips and Tricks, so I thought I'd just cover some tips and tricks with a couple of case presentations. So the first really, and I would say from my perspective, most exciting innovation in terms of stroke is stroke protection and the use of a Sentinel device, stroke protection device. It's quite a smart little system. You use the right radial, 6 French, so quite small, just like a diagnostic coronary angiogram. It consists of 2 filters, the first of which is this large filter, the proximal filter, which is delivered into the brachiocephalic, right brachiocephalic, which is obviously the main common artery before the right subclavian and right carotid. You then manipulate the tip of the system around the corner and up the left carotid and deliver another distal filter. And this allows us to catch any debris, whether that be calcific or thrombus or anything else, and reduce the rate of stroke. Obviously, the bacilla of the vertebral artery from the left subclavian isn't protected. And there are some other devices which cover all 3 of the major arteries coming off the arch. Clinical data at the moment is relatively limited. For clinical outcomes, reduction in stroke, we have mostly observational data with all its caveats. Randomized control data with combined but surrogate endpoints, meaning imaging endpoints, mostly cardiac MRI and careful neurological examination, are available and do show an advantage in terms of surrogate endpoints. And of course, we await the protected TAVR study, which is randomizing now and has been led by Boston Scientific. First case is an 85-year-old known with atrial fibrillation, previous stroke, on a NOAC, severe aortic stenosis with moderate annular calcification. So all in all, a high-risk patient with the amount of calcification and the AF risk factors. We also find, or we had found, that these patients on NOACs, when we stop them 5 days before the TAVI although not scientifically proven, it was our experience that there seemed to be some hypercoagulability type pattern to some of these patients, which seemed to make them a lot more prone to clots and thrombus than other patients. Whether that was the initial disease or the use of a NOAC, we don't know. So you can see here my pigtail in the arch is an LEO 30, just to open out the arch. You can see the moderate calcification before the contrast comes in there. And I apologize for not having the fluoro saves of the delivery of this. Actually, I must admit, we've only just started using the Sentinel device. And this case was from just 2 weeks ago. It was actually my first use of Sentinel. So we're relatively late in using it in our center in terms of Scandinavia experience. It's very easy to use. It added 5 or 6 minutes onto the procedure time. It was very intuitive and delivered quite nicely with no great drama at all. You can even see that the device is hanging out a little bit into the arch. Actually, that didn't cause an issue either, you can see later. And then we'll just see a positioning shot here. This is a MyVal. And delivery of the valve. My focus on stroke prevention has been very much to do with thrombogenic type reduction, really managing the patients, managing ACT, doing all those things. And what's quite surprising at the end of the case is what you collect. This is from the same patient. And it's quite hard to get scale here, but these are 1 to 2 millimeter hard chunks of calcium, and no amount of ACT measuring or careful manipulation of antiplatelet drugs is going to change this fact that this calcium probably more than likely came from the valve on implantation of the valve, from the old valve, and those were going towards the head and at least causing a lacunar infarct, possibly more. And I've used this system, well, just 10 times now, but I think there's only been one case where we haven't collected a significant amount of debris. So that's Sentinel, a big tip and trick for me, a big innovation in TAVI, and I have no doubt that protected TAVR randomized trial will show some advantage to that system, and we're very comfortable using it and very happy to be able to offer it to our patients when we consent them. Next case is another sort of extreme, well, not another extreme, but an extreme TAVI case. This is an 89-year-old lady who was desperate, had minimal comorbidities. Some 9 years ago, had a MitraFlow 19 millimeter surgical valve implanted. Now had a peak gradient of 130 millimeters of mercury with a 60% ejection fraction, NYHA class 3, desperate with multiple admissions to hospital, decompensated and heart failure. The smallest TAVI that we have is 20 millimeter Merrill MyVal. And her MitraFlow, if you look at the valve and valve app, the true internal dimension is just 15.4 millimeters. So we had minimal, you could argue we had no options to treat this patient with TAVI. But we're quite fond of offering these patients some kind of treatment. And for her, we had a careful discussion about a relatively high risk valve fracture technique, which would allow us to implant the 20 millimeter MyVal. That involves, there are 2 different ways of doing it. Just flip to my next slide. There are 2 different ways of doing this. You have to crack the annulus of the surgical valve, the ring. This is only possible with some valve types, but with MitraFlow you can certainly do this. And you can either implant the valve first and then use an oversized balloon, usually 1 millimeter larger than the external dimension, which is 20 millimeters, and crack the annulus afterwards. Or you can crack the annulus before and then implant the surgical valve, the TAVI valve. We decided to do the latter, put the patient on CPS, crack the valve with a balloon, and then implant the TAVI. And the main reason for that was because we thought with an internal dimension of just over 15 millimeters and a 20 millimeter balloon, valve, there was potentially some risk of getting in a very sticky situation with a dysfunctional valve and a crashing patient before you've managed to fully deliver the TAVI with the post-adaptation and rupture of the sewing ring of the surgical valve. So we put this patient on CPS. That is primarily because you do a very long pacing run and gradually come up with the pressure on the balloon. And you can see the CPS venous catheter down here. So it's quite a big setup. You've got, I was using 6 proglides, 2 in the vein, 2 in each artery. This 89-year-old had perfect iliacs, so she was quite an amazing lady. And here you can see our balloon coming up. And you can see the wasting there, significant waste. Is a 20 millimeter balloon. So that accounts for the 15 millimeter internal dimension. I missed some of the cracking. It actually cracked twice. You can feel it as you come up with the indiflator. You see here it's cracked already a little bit, and then it just gives and straightens out the balloon here. So that's the sewing ring of the surgical valve is split and allows implantation of a larger valve. Actually, with her, we had all sorts of plans A, B, and C for her, for all sorts of eventualities, but it actually wasn't really that traumatic. She tolerated it very well. She was conscious all the way through with minimal sedation, and she was chatting with us. And yeah, I think really with these cases, they're like most complicated TAVIs, they're won and lost at the iliacs. So especially an older patient with a double large bore arterial and a large bore venous, it's absolute attention to the details, using ultrasound, steering around calcium, etc., etc. And that was our final results. These patients are at high risk of obstruction of the coronaries because of the old surgical valve leaflets folding back, but luckily this patient didn't have any issues. So the results were actually her residual gradient after the surgical valve 9 years ago was 35 millimeters of mercury. The residual gradient after our TAVI some 9 years later was just 9 millimeters. So we saw that as a great victory. They have a high risk of stroke. We did this before we started Sentinel, but we would have certainly used Sentinel with her if we had the chance. They also have a risk of annular rupture and coronary obstruction. Patient was discharged 48 hours later, 89-year-old, discharged 48 hours later, no complications, which we were very happy with. I think I've got time just to cover a last case, some interest to you perhaps, and perhaps a bit more tips and tricks. An 82-year-old with complex iliac disease and severe aortic stenosis with multiple comorbidities. Certainly wasn't a surgical candidate with a very high STS score. And we didn't have any other options. She had a lot of auxiliary disease. She had, because of the trouser graft, she didn't have a transcavernous option. She got a previous aorto-iliac trouser graft, severe calcific aortic and iliac disease, anastomosis stenosis, and abdominal aortic stenosis. Abdominal aorta stenosis, 2 of them. Just going through the CT here, this is playing, I can't control this, I've just done a little screen grab. You can see at the top the calcium in the annulus and the arch, and if you cast your eyes down to the mid-aorta, it is just full of so much calcium. There's 2 stenosis in the abdominal aorta, one just by the celiac plexus. And I think I'm going to scroll down a little further down now, so you keep your eyes just where the kidneys are, mid-abdominal aorta. A little slow here. There you go, there's the first stenosis, which I think is just after the anastomosis of the trouser graft. Those are the 2 trouser grafts coming down. It's a complete mess there, as you can see. So we've got the right iliac, which is our option. She had a lot of calcium in the access sites in the right femoral, but we very much like to use ultrasound to steer around that calcium and to allow the proglides to deliver properly. And I've really changed my practice with ultrasound in the last 2 or 3 years, and it's really, I think, improved my possibilities to treat these patients without complication. So the first is actually a small dilator here. We've pre-treated the iliac with a 6 or 7 millimeter balloon all the way up to the abdominal aorta. We've then got the sheath in, and so there's the large dilator, I think, with the sheath in as well, if memory serves me correctly. And now you see the tip of the sheath is above that balloon, and what we now do is, the situation we don't want to get caught in is that these are expandable sheaths. So they start at 14 to 16 French, but as the valve goes through, they expand, they split and expand up to around about 22, 24 French, which is about 8.5 millimeters. So the situation you don't want to be in is that you've delivered the sheath, you come up with the valve, and suddenly, because of calcific disease, you're stuck midway in the sheath. You can't get the valve going forward, and you can't get it going backwards. So we use a very gentle technique with an 8 or a 9 millimeter balloon and dilate inside the sheath all the way down, which gives us the confidence that we are going to be able to deliver the valve. And also, if you see, it's also treating the iliac as you go up, but it's treating the iliac in a very gentle way. Of course, it is possible to have such severe calcific disease that you can't dilate it, and we have used shockwave balloons in the past, but it's actually quite seldom to have to do that. Most of the iliac disease does dilate quite easily. And there we are, all the way up to the heart, no drama, wire across the LV, and delivery of the aortic valve. The most important thing in these cases that you've got both aortic and iliac disease is to have a plan B and C for any complications. So iliac perforation, aortic perforation. And I discuss this with our peripheral interventionists, who I discuss a lot of the CTs with and have a good working relationship with. So we had covered stents available for the iliacs. We had a large covered stent also available for the aorta. And of course, at the end of the case, there's the final TAVI picture. And at the end of the case, the most critical is a very careful look at for any complications in the aorta, which may happen straight away, may happen after removal of the sheath. You can see this abdominal aortic stenosis, which doesn't look very severe, but it was really quite severe. I toyed with the idea of using a large, long sheath, but decided not to. And then another picture with the sheath all the way back, and the most critical part of the iliac disease. And you can see here we have no issues, no dissections, no drama, just a happy patient. The thing that she was complaining of was quite severe ischemic pain in her right leg, and that was because we were occluding the iliac throughout the procedure. Those are my cases and my presentation. I'd happily answer any questions when the panel starts. Feel free to contact me with any questions, either by email or Twitter, and I hope that was useful. Thank you.